Welcome, everyone, to today's webinar, Integrating FGS to Optimize Women's and Girls' Health in Africa. Our webinar today is co-hosted by the Canadian Network for Neglected Tropical Diseases and the FGS Integration Group, or FIG, in recognition of International Women's Day tomorrow. I'm Alison Krentel. I'm an associate professor at the University of Ottawa's School of Epidemiology and Public Health and the current chair of the Canadian Network for NTDs. Bonjour et bienvenue à notre webinaire aujourd'hui. La session sera présentée en anglais, mais n'hésitez pas à poser des questions ou à faire des commentaires en français. In Canada, we begin official meetings such as this with an acknowledgement to the location from where we are in the country. I'm speaking today from Ottawa, and so these remarks reflect my current location. Here we pay respect to the Algonquin people who are traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous peoples in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional keepers, both young and old, and we honor their courageous leaders, past, present, and future. This year's theme for International Women's Day is Accelerate Action. For those of you unfamiliar with female genital schistosomiasis, or FGS, it is a disease that is estimated to affect up to 56 million women and girls in Africa. To address FGS, we must accelerate action to ensure that women and girls are protected from infection, and if they are infected, to ensure that they receive the care and treatment they need. Today, we have a great panel of engaging experts. Each will share their unique experiences in addressing FGS across Africa. Our speakers will showcase different ways that FGS can be integrated into the health system, and they will suggest opportunities for scale-up and sustainability of action. We'll open our session today with some remarks from Neelam Asmit, a portfolio manager at Grand Challenges Canada in the Global Health Innovation Team. She leads the medical products and technology portfolio, which seeks to support the most promising innovations in low resource settings. Welcome, Neelam.
Thank you so much, Alison, for giving me the opportunity to speak today. Good morning, good afternoon, everyone. I would like to start off with the fact that unfortunately we can confidently say that FGS is one of the most neglected SRHR diseases. And as you already may know, it is a multifaceted, complex issue. It is more common among rural and vulnerable populations that lack access to clean water and sanitation. So it's farther away from what would be the urban hubs. And it is a heavily gendered issue. Like Alison said, approximately 56 million women and girls in the African region may be affected by FGS. It can put women at 3 to 4 times greater risk of acquiring HIV and at a greater risk of contracting HPV and cervical cancer. And despite its impact on women's health, it is typically an overlooked area in medical training and remains poorly recognized with low awareness, both in the affected communities as well as in health professionals. And I say this with that, like I said, unfortunate feeling that this is an area that we still have barely scratched the surface on. We still don't know the depth of its impact on women's health. And all this sounds very dark and bleak, and as it is, but I do want to move towards some more optimistic tones around it. And I do want to say that while we might not know the depth of this issue, we do have sufficient research and data to act. And I think that is the critical part, that we need to take action to respond to this endemic. GCC has been a proud partner and early stage investor in the FAST package. It's a comprehensive evidence-backed innovation to address the multifaceted nature of FGS. I won't speak much to it because you would hear about it, and I don't think I'll do justice to the innovation by explaining it. But what I do want to talk about is what really stood out to GCC in this innovation in the FAST package within our engagement and investment in the package. So what really stood out to us was the innovative approach to address FGS at an individual, community, and health systems level. I think that was a key critical component that built our confidence in the solution. The integration of the FAST package into existing education and health programs, particularly primary healthcare systems, was something that was the key highlight. And I believe the biggest component that gave us confidence to invest in the solution. So it's a holistic approach that is systematic in nature. And we strongly believe that that is the future of eliminating FGS. Holistic approaches that are systematic, that are integrated into primary healthcare systems, and reaches those that are at the highest risk of contracting FGS. And that basically means a coordinated approach to engage all stakeholders. And while a coordinated approach was always something that was critical, even back in the day, I think it is incredibly important and pertinent in the current environment that we are in. Looking at the current socio-political environment, it is incredibly important for us to rally together and look at coordinated approaches and address such multifaceted issues. And it can no longer be the way we used to function. In the past, coordinated approaches just with the public sector were sufficient. But in the current environment, we need to be more creative with how we engage others. And we need to leverage other partners, including the private sector. So I would like to close with the remark that I think it is it is critical time for us to rally behind this issue and come together and be on the same side of resolving FGS and eliminating it. Thank you so much, Alison.
Thank you so much, Neelam, for opening our session today and for taking that first investment in large-scale investment on health systems integration for FGS. So now it's my pleasure to pass the microphone to Dr. Pamela Mbazi, a physician and medical epidemiologist working in the Department of Control and Neglected Tropical Diseases at WHO headquarters in Switzerland. Pamela has championed FGS action for many years at the global and national levels. And years ago, we welcomed her to Ottawa to speak about FGS in a small room. There weren't a lot of people there. So it's great to see how FGS action has grown from that time. So I'm delighted to welcome you as our moderator for the session. So thank you. Over to you, Pamela.
Thank you so much. Good morning, good evening, good afternoon, some of you as well. I'm really, really honored and privileged to be able to participate in this webinar today, alongside a wonderful panel of experts and implementers and supporters of this issue, as you're going to hear shortly. And on this Eve of Women's Day, I'm very glad to have this women-only panel to also showcase what they have been doing in different ways as from being researchers, implementers, to donors working to address this issue. So I will introduce our first speaker. I believe you've all had a chance to see the bio summaries, and I'll only say 2 facts so that about each of them, in addition to saying their names. So our first speaker is going to be Dr. Professor Margaret Japon, University of Health and Allied Sciences. She's originally from Ghana. Her background is in medical anthropology and cultural epidemiology. She's done a lot of wonderful work related to communicable diseases across the board globally as well. One key factor I'll highlight about her as well, related to the FGS topic, is that she has really done groundbreaking work to show the gendered effects of neglected tropical diseases, but with a specific focus on female genital schistosomiasis. So over to you, Margaret. Please do present to us what you've been able to do related to the first package that was mentioned by Neelam, and how this has been taken up and influenced the space for intervening for FGS in Ghana. Over to you, Margaret.
Thank you very much. Put this together. When I saw the program, I said to myself, one of my dreams when I started FGS has been fulfilled. We are talking about FGS, but not in an NTD forum, but in a women's forum. So I'm kind of feeling very fulfilled this morning. Thank you so much to all of you, and happy International Women's Day. Can I have the first slide, please? Thank you. So I'll be talking about, as has been said, the FAST package, a piece of work which initially was done in Ghana and Ethiopia, and then, Ghana and Madagascar, and then later on we included Ethiopia when we got onto the second phase. FAST package, full meaning FGS, accelerated scale together package. Next slide, please. And I'm presenting on behalf of ladies and gentlemen from all the different institutions that you saw listed beneath. And on the last slide, I'll be acknowledging all of them. So like I said earlier on, we initially started this piece of work just after COVID or in between COVID. We're funded by Grand Challenges Canada, and we worked in Ghana and Madagascar. In Ghana, we worked in the southern part of the country and the north and the southwestern part of the country. And in Madagascar, we worked in the Morondova district. And then after we completed the first phase, we got funding from the End Fund, thank you very much, to continue some of the work in Madagascar and then to include another country, which was Ethiopia, because End Fund was working in those areas and it was only too natural to bring this together. The interesting thing is that even though Ghana did not go a second round with this, you see from the subsequent slides that we were able to use local resources to be able to move a lot of issues related to the FAST package forward. Next slide, please. So from our training, many of us are trained in a very siloed way. You are a medic and you are trained to look at things in a medical way. You are in public health, you are trained to look at things in a preventive way. And thereabouts, you're a teacher, you are trained to teach in the classroom. Now, many of our interventions are presented at country level or at the community level in silos. But for the FAST package, we thought that it would be better to bring all the interventions together, training medical personnel, teaching them diagnosis and treatment, creating awareness at community level, and also working with the NTD program through the Mass Drug Administration as they implemented it to ensure that cases were prevented through preventive chemotherapy. And on top of all of that, we established the FGS national committees in each of the various countries so that people, policymakers, program implementers, stakeholders could form themselves into a group and take up the issues that we were discussing to a higher level after we had completed the work on the FAST package. Next slide, please. Now, if you look at the life course of a woman from birth to post-reproductive age, you find out that when you are born, freshly born, your risk of exposure to schisto is quite small. You are not engaged with issues around prevention of FGS or even progression onto FGS, and there's no issue about diagnosis and treatment of FGS. But as you move along the scale to adulthood, you realize that you have the engagement with exposure to schisto infection. The young girls, by virtue of accompanying their parents or their siblings to the river bodies, to bath, to swim, to play, or to assist their mothers in their daily chores. Now, if you look at this slide, you see portions in red, and those are the areas where we focused on when it came to the FGS. So generally in the communities, a lot is said about schisto, but when it came to FGS, we had to create the awareness in the communities because people really did not know about it. Even amongst our health workers, some of them didn't think that FGS happened. They didn't think that women pass blood in their urine. They felt it was only men. So we created a lot of awareness in the communities, and then we supported the Mass Drug Administration with age-specific appropriate information about the condition because our health workers and community members were not aware of what was going on. And we provided FGS information through the existing mechanisms and structures at the community level and at the district levels, using all appropriate avenues that already examined women in the health facilities. And then also in terms of diagnosis and treatment, you heard about FIG. We worked with our colleagues from the Geneva Learning Foundation to take people through the diagnosis and treatment at all levels of the life course of a woman. Next slide, please. Now, on this slide, we are using the health systems building blocks as a basis for the things that we are going to say that we implemented during the FAST package. So I talked about education, and one of the things we did was to produce materials that we could integrate into the health system. But let me say that we didn't just develop these and throw them into the communities or to the health facilities. We got our health providers, our program managers, those are the districts and community levels, to go over these booklets that we developed. So if you go on the website, you see some of these booklets out there. We even got some school children to be able to give us comments on it, and their inputs were really incorporated into this. A lot of the basic information was based on the formative research that we conducted. There was the educators booklet, which the teachers could use to be able to teach the children in the schools. There was a parent tip sheet, which had questions that parents could read over and then respond to any questions that children had. And then we had the adolescent storybook telling the case of a young girl, Salma, and her action against FGS. Quite interesting. So if you have time, just go on our website and look at all of these have been approved by the Ministry of Health and also the Ministry of Education. It is currently in 5 languages: Malagasy, French, English, Amharic, and then also an Ethiopian local language. Next slide, please. So further integration into the health system, we went into details about treatment for suspected FGS cases, and we're advocating for the use of praziquantel, which is left after MDA, to be used in those health facilities. Previously, that was not the case, and we really are grateful to the WHO for including it in the current version of the treatment guidelines for schisto. So currently, at post-MDA, the drugs are left at the health facility so that people could use. Then in one of the countries, we had a tracking sheet where health workers could track the people they are treated with praziquantel. Like I said, we trained a lot of health personnel and then created materials for them to be able to use. In some of the countries, some of the information has been incorporated into the training curriculum in our training facilities. Next slide. And then further integration into the health system. Some of our health workers who were part of the Geneva Learning Foundation training had their competencies. We developed core competencies for them, and then we organized a training of subject matter experts in the countries, particularly in Ghana. There was a lot of peer-to-peer learning, and many of the issues we talked about have been incorporated, like I said, in curriculum, particularly in Ghana, where we had the head of the training institutions, head of gynecology as part of the training, and they've incorporated quite a bit of it into the curriculum. Next slide, please. And then I talked about the FGS National Committee, and in Ghana, it's very, very vibrant. We have the NTD program manager chairing this committee, and post-FAST package, any district or region they go to where they are talking about schisto, they raise the issue of FGS. And so when you come to the country, there are quite a number of people, health facilities, regional level, who know about FGS. We've just completed one district where we are mapping the prevalence of FGS. Next slide. I see Pamela is working. So what works in this approach? The national committees I found have been extremely helpful because we have people at the highest level getting involved and sharing the information about the FAST package. The sustainability of the training, the subject matter experts have been wonderful, and many of them have gone on to further degrees studying issues around FGS and are championing the cause in the various countries in which they belong. And strengthening the health system further. Now we have indicators in the district health management information system, which is something that is quite laudable. last slide. That's what we have done. And I want to acknowledge all of these people, institutions, funders, everybody for supporting us in the first package. And I know they'll continue to support us. Kindly visit us, our website, for further information. Thank you very much for the opportunity.
Thank you so much, Margaret. Thank you so much indeed for sharing with us and highlighting yet again what you have done and taking us on a tour from Ghana, Madagascar, and Ethiopia, and showing us how you've applied your knowledge and agency to this amongst this panel of women. Thank you. Our next speaker is Leonora Pili. She is the lead for HIV prevention advocacy at Frontline AIDS and is a co-chair of the FGS integration group called FIG in short. You have her bio sketch. I won't say too much about her, but one word stood out for me, which is fierce. So she's described as a fierce HIV prevention advocate, and we are fortunate to have her work with us and support this work on FGS. So please take us through with sharing your presentation on FGS integration using the minimum service package in Kenya. Over to you, Leora.
Thanks so much, Pamela, and thank you for having me. I'm going to take you through the development of another way that FGS has been integrated into services, but through a sexual and reproductive health lens. Next slide, please. So we developed a minimum service package for FGS and SRH integration, and this minimum service package was developed as part of a program called the FGS Integration Project, funded by SIF, and through partners, Frontline AIDS, Bridges to Development, and LVCT Health. And the aim of this package was to fill programmatic guidance for health planners, programmers, and policymakers, to really provide concrete guidance on how to integrate FGS into an SRH program that already exists. So the MSP intervention integration was split across 4 areas, the first being health literacy, screening and diagnosis, treatment and care, and then a cross-cutting element, social inclusion and equity. Next slide, please. So the first section of the MSP focuses on health literacy, and it outlines how FGS information can be integrated into SRHR, health literacy and demand creation activities. The type of FGS information that should be included in these activities would be FGS signs and symptoms, the links with HIV and cervical cancer, the overlap of symptoms with STIs, the screening process for FGS, and then FGS prevention and access to safe water. Essentially, this information on FGS would be provided to a patient or a client during information around family planning, cervical cancer, HIV, and STIs. The MSP also goes into detail on who would do this. So it would be done by peer educators, community healthcare workers in communities, schools, and also within facilities. The MSP then goes into the second section, which is around screening and diagnosis. And it outlines how FGS, risk assessments and screenings, as well as how FGS can be diagnosed through a pelvic examination during routine SRHR interventions such as STI screenings, HIV testing, cervical cancer screenings. It also outlines how applicable referrals should be made depending on the patient and the comorbidities that may exist. And it outlines obviously that clinicians specifically and nurses would do this and how it could be done in different levels of facilities, primary, secondary, and tertiary. And then the third part of the MSP outlines treatment and care. And it speaks to how praziquantel can be provided as treatment or prevention alongside FGS syndromic management during SRHR services, such as providing STI treatment, family planning medication, conducting support for cervical cancer, and then also HIV treatment. And of course, appropriate referrals, and that this would also be done by clinicians and nurses in these levels of facilities. But the MSP also includes a wider piece, which is around social inclusion and equity. And as part of this, it speaks to how all members of staff that are providing FGS services, whether that be clinical services or information, need to be aware of the mental health support element that needs to be included. And this is because the diagnosis of FGS is incredibly difficult for some women to handle. It's also incredibly difficult for some women who might have experienced long-standing stigma in their communities for having a recurring STI and having constantly been misdiagnosed, which requires mental health support. Additionally, all staff need to be aware around the inclusion of gender-based violence. That is a possibility for women who may have been labeled as promiscuous for having a recurring STI when in fact having FGS. And applicable referrals need to be in place to ensure that you can support those women. And then at the same time, everyone should be doing advocacy to reduce barriers to FGS services. So this would include advocacy to include praziquantel in primary healthcare facilities and in facilities more generally, and not just having it available in MDAs. And then also, creating awareness around FGS to whoever and within communities. And this should be done within the community, the wider community, as well as in all facilities. Next slide, please. So just to speak how the MSP fits into the wider health system, the MSP focused on service delivery, as mentioned, but it also touched on human resources, as there's an element in the MSP which outlines how community healthcare workers, peer educators, clinicians, and nurses need to be trained as per the health competencies, which Margaret had referred to. It also speaks to how medicines and technologies can and should be used and how that should be integrated into the healthcare system. And I will speak about the implementation in Kenya briefly, but that actually resulted in a lot of the technologies, such as the colposcopes, being used that were within government facilities already. And it also speaks to how the project, the implementation of the MSP, managed to contribute to the purchase of praziquantel in one county for greater sustainability and access to the medication, more, for women in those facilities. In terms of governance, the MSP was contextualized per county in Kenya. And engagement was done with the national and the county levels in the Ministry of Health with both the SRH and the NTD leads. And so the MSP has really tried to integrate into the SRH program and not be so expensive to implement. Next slide, please. So the implementation is happening in Kenya, and we've got fantastic colleagues from LVCT Health on the call. And we've got some data that we can share around lessons learned. And what we can see thus far is that the integration of the FGS in the MSP through SRHR services has really shown a high level of acceptability amongst women and girls, as well as the government. And that community and one-to-one engagement used for sexual and reproductive health rights interventions, including HIV prevention, is really an effective model to talk about FGS due to its personal nature, particularly the symptoms, the stigma, and it's really, really useful for FGS-related stigma interventions, referrals. The implementation has also really shown that there's high government acceptability and buy-in, and that's seen by the procurement of praziquantel in one county, particularly to be routinely available in the healthcare facilities. And the one other thing that the MSP has really demonstrated is that working within communities, even though our focus is on FGS because it is a particular woman, female issue, and the side effects and the symptoms and the risk that women face are incredibly high. We also cannot ignore male genital schistosomiasis, and it needs to be covered equally and alongside FGS in those community engagements and one-to-one conversations. Something else that the MSP has shown is that there's a higher number of FGS positive cases detected in lower level facilities, and that healthcare workers were really eager to learn about FGS, and that more emphasis is needed at the health level, at the health planning level and the policy level on this work. And then finally, what the data is showing is that there's a massive coexistence of HIV, cervical cancer, and FGS, and that a lot of women in these counties in Kenya are suffering from a double or a triple burden of HIV cervical cancer and FGS. And thank you so much.
Thank you so much, Leora. Thank you so much for sharing this really practical example of how to use a sexual reproductive health rights approach to addressing this comorbidity with HIV and also with the cervical cancer and other conditions that already burden women in these situations. Indeed, your fierceness as an advocate has come through your presentation. Thank you. To our audience, which is of more than 100 people online, this is to remind you that we'll have a discussion and a Q&A session after the presentation. So please feel free to start typing your questions in the chat and indicate to whom you'll be directing that presentation. Our next speaker, I'm pleased to present and introduce Ashley Preston, who is a technical advisor with Access and FGS at Unlimited Health. She will talk through how to strengthen patient-centered sexual reproductive health systems through integration of FGS and share an example that of her work from Côte d'Ivoire. Importantly, I'd like to mention she's part of the project, the ADOPT research project that's working on pediatric praziquantel. So to show you that we are indeed looking to see that as we address this, we leave no woman behind. And we look forward to hearing what you have shared with us, Ashley. Over to you.
Thanks very much, Pamela, and hello, everyone. So I'll be speaking about the work in Côte d'Ivoire, as Pamela said, and particularly our work with the Ministry of Health and the NTD program within that. So next slide, please. And firstly, just to give some context on Côte d'Ivoire, aside from the project that we're working on, there's no routine services available for FGS prevention or care. And praziquantel is not routinely available in the health centres, and it's expensive to access through other means like pharmacies. And based on our baseline research in Subre district, we found that the knowledge of FGS amongst at-risk women was really low, and that's the same for health workers because they're not routinely trained on FGS. Next slide, please. So our focus with the Ministry of Health in Côte d'Ivoire is really around prevention, and the rationale for that is that as FGS progresses and lesions develop, it can become increasingly difficult, and praziquantel may not be as effective anymore at reversing all of those symptoms. So our aim is really focusing on prevention and finding women as early as possible. So our approach is around integrating FGS prevention with routine sexual and reproductive health services, including HIV/AIDS services for prevention, testing and treatment, also services for STIs, testing and treatment, and then any services involving gynecological examination, for example, antenatal care. And the way integrated services are provided is that during sort of routine consultations with health workers alongside the standard care, FGS prevention is also provided to at-risk women. So preventive chemotherapy is provided, praziquantel, to the women, and that's without diagnosis because of the focus on prevention. And then that's also alongside FGS health education. Next slide, please. So how was integration achieved in Côte d'Ivoire? And that really, the first stage was really around planning and making sure that we understood the context. And as you can see, that sort of involves all of the building blocks within the health system because they're all interlinked. So firstly, understanding, for example, the service delivery that already existed in Côte d'Ivoire, understanding the information systems, what's reported, who's involved in those reporting systems, and also the resources already available in the health centres. And then additionally, understanding who are the stakeholders. So not just the resources, but so that involves the human resources, but also at the governance level. And one of the things that really helped us in the project was the formation of the FGS working group in Côte d'Ivoire, including members from the NTD program in the Ministry of Health, HIV program, maternal health, also relevant research groups, and the international information system. And in the future, they're hoping to reach out to the FGS Gynecology Society, the National Gynecology Society. And then the next step after understanding the context was developing all of the material. Thank you. Developing all of the materials to be ready for implementation, so that what we were calling the training and learning resources package included all of the training materials, and then all of the materials that would help health workers retain their learnings from the training, so job aids and things like that, materials for reporting, and then also thinking about IEC materials for raising awareness. Next slide, please. So after that, the training was conducted with health workers. So that included all of the doctors, nurses, midwives who provided first point of contact consultations in the sexual and reproductive health services. And then also training of community health workers, who are such an important contact point for women in the community. So essentially that brings me on then nicely to step 4, which was around community sensitization, because it's so important to raise awareness for women in the community. And although it's not strictly one of the building blocks, you can see that people are in the center of the health system and the services. So we targeted all of the villages in the catchment areas for the selected health centres to provide FGS health education, raising awareness and increasing demand for those services. Next, please. And again, thanks. So then after all the groundwork was laid, it was possible to then implement the integrated services. So again, that is relevant for all of the building blocks in the health system. So the FGS prevention services were provided alongside the routine sexual and reproductive health services. And it also involved thinking about, praziquantel availability. As I mentioned, it's not available routinely in the health services. So in the context of the project that we were working on, we had to actually purchase that. But then the expert working group's going to need to work on kind of ways of finding a sustainable solution moving forward. Also thinking about reporting, so having the correct information of the women who attend the health centres and reporting that up the system, and then thinking about the supervision and financing. And of course, then that's also important to have processes for evaluation and refining the strategy. Next slide, please. So then that brings me on to what worked, and this is the approach based on the research that we're moving ahead with. So firstly, focusing on women in the community, it's really important to have community health workers engaged, because we found that they were a really important link between the women at risk and the health centre level. And then when those women attend the routine sexual and reproductive health services, those integrated services we found were really found to be an appropriate way to actually engage those women And also the training of the health workers was really well maintained during the course of the project. So during that routine consultation, one of the things that we suggested to further refine the strategy was to actually include better targeting of the women through the use of an FGS risk assessment questionnaire. And there's a lot of work in different groups going on that. So I'm interested to see where that goes in the next few years. And then following on from the kind of routine health worker consultation, collecting those cases of at-risk women and building a surveillance system that will help effectively target people in the community and areas at risk. And so it's really important that strategies in the health centre go hand in hand with community outreach and effective integrated prevention programs. And so next slide, please. I'd just like to say thanks to everyone involved, particularly the Ministry of Health and the NTD programme, and then the health workers and women involved as well, of course. Thank you.
Thank you so much. Thank you so much, Ashley, for that example. You've taken us to Côte d'Ivoire. And now, as we come nearly to the end of this segment, before the questions, I will invite our next two speakers, Ruth Schumer, who's the head of a global program, Pandemic Resilience, One Health at the GIZ Finance, GIZ, which is financed by the German Federal Ministry for Economic Cooperation and Development. She's a physician with nearly 30 years of experience in this work. So all our previous speakers, none of them has been a physician, so it's the first physician we're going to hear from. It's wonderful. And you will be sharing the spot with Chimwemwe Lita from Malawi, who will also be showing us in real practical terms what everything we've said and had has meant and helped her with her work as an implementation manager of the GIZ Female FGS initiative in Malawi. So over to you, Ruth.
Thank you so much for this wonderful introduction, and honored to be here. The initiative we are going to present from the GIZ side is called From Neglect to Action, Invest in Health, Invest in Women, as an initiative to reduce female genital schistosomiasis. Please continue to the next slide. This is the team which is growing, actually is particularly growing in Malawi, but for the moment being these four pictures for you. And Chimwemwe will take over just after me. Continue. The German FGS initiative sits within a much larger global program, which is called Pandemic Resilience, One Health. In this global program, we treat neglected tropical diseases as one of the focus areas. The FGS initiative was launched at the World Health Summit 2024. Some of you remember, because I remember you being there. Look at the picture on the right-hand side below. You can see that this was pretty much high level. I don't know if you recognize the people. There's our German minister, Svenja Schulze, coming from the Ministry for Economic Development and Cooperation, and the minister from Malawi, the health minister from Malawi, but also it was launched together with UNFPA, USAID, quite a great event. So this is the political part, that the global visibility political part. If you look again at the right-hand side, you see a brochure which is on the feminist development policy, which was launched in Germany before the FGS initiative in the economic development and cooperation ministry, but just as well as foreign policy. Why do I mention this? Because I think FGS is not only about women as victims, as patients, but particularly about empowerment of women, of taking an active role in FGS and tackling the FGS. As said, the launch has happened at the WHS in 2024. So we started in September 2024. We are relatively young initiative. Right now we have a project perspective till August 2026, but we intend to prolong it for another year. And as already said, we have two parts to the initiative: the global partnerships and progress part, and secondly, the Malawi part, which is direct country support with pilot measures. Continue, next slide. So the overall goal is to accelerate international efforts and progress to eliminate FGS as a public health problem. And this is very much in line with the WHO roadmap for NTDs. We have quite a number of partners, particularly WHO, as already mentioned, but also the Canadian network, ASPEN as the regional network, but also civil society, and of course, endemic country governments, particularly Malawi. Chimwemwe will come back to that. On the global level, our objectives are to strengthen strategic global alliances, mobilize support, and raise awareness. As was mentioned at the beginning by Pamela and Neelam, FGS is the most neglected of the neglected tropical diseases. So I think also globally, it's important to raise more awareness, but also to improve data and evidence. So we are working also with WHO and partners and ASPEN to improve data collection on FGS. I'm not only speaking about research data, but particularly systemic data, and thanks to our colleagues who have already been working in Madagascar, who have moved forward on this. And finally, increase the efficiency of the financing, but also to raise financing. Now we move on to the Malawi context, and I will hand over to Chimwemwe. Thank you so much.
Thank you, Ruth. I will take it from here. Of course, in the interest of time, I will just run through this quickly. So as you can see on the slide, that's the map of Malawi, and it's covered. 20% of the land is covered by water. If you can see the map, the gray area, that's Lake Malawi. It basically runs from the northern to the southern region of Malawi. So that already puts Malawi at a higher risk of FGS. So if you look at our data, the current NTD master plan of 2023 to 2030, you will note that schistohematobium, the prevalence, it's above 50%. So with that prevalence, I mean, FGS, it's endemic in Malawi, almost all the districts. However, for this project, we are only implementing in 2 districts, Dedza and Salima. Salima is also along the lake. Part of data is along the lake as well. Next slide, please. Yes, so with that background, what we are doing in Malawi basically is to work together with the ministry to reduce FGS. And we are doing that by contributing to the elimination of schisto as a public health concern in Malawi by 2030. And this is informed by the current NTD master plan. So as I already indicated, we are in 2 districts of Dedza and Salima. We have started small. Basically, we want to learn how can we integrate FGS in the pre-existing services, and how will that law, if the ministry can take it up to the rest of the country. But at this point, it's a learning space. And I'm happy that most of the presentations today are really going into, have gone in the direction that we have also taken, and it's a great learning space. So looking at our outputs, what is it that we want to achieve at the end of the 2 years project implementation? So first of all, what we have started working on is integrating FGS management into the pre-existing services. So we're talking of SRHR services such as cervical cancer screening, family planning. Already FGS management has been included and are integrated in the treatment of the STI treatment guidelines. So we want to take it further, not only concentrating on a few service packages so that we reach a lot of women. And as Ruth also just highlighted, what we want to do in the program is to make sure that we empower women. They should be active participants in their own taking care of themselves, but also reaching out to their communities, reaching out to their fellow colleagues, fellow women, reaching out to their daughters. So in that area, want to build their capacity. They should be advocates of FGS services in their facilities as well as in their communities, in addition to being advocates for WASH knowledge and championing the same in their communities. And we realize we cannot do this without data. And you might agree with me that most of the countries in especially in the African region, do not have adequate data that talks about FGS. And even when you look at the DHIS, you will not find indicators of FGS. I'm happy to learn that Ghana has that, and probably Malawi can also learn from there. So we want also to work in that space, making sure that we have comprehensive reporting structures as well as tools. And the last bullet, it's not very different from the first one. Basically, we're looking at making sure that we have available at the policy level. We have documents available. We have training packages. We have guidelines and protocols. Next slide, please. So this slide basically is just painting us a picture of how we want to do our integration. And as most of the previous speakers, I think basically we are also going in the same direction. When you're looking at the people, it's a matter of building capacity of women who are the main beneficiaries of the program. So we want to empower the women and girls. They should be active participants in their own care, as well as much when we build their capacity, they are knowledgeable, they are aware of FGS, they'll be able to reach out to their colleagues with comprehensive information on FGS. And then in terms of medicines, we know MDs, I think it's one of the most important channel for dealing with FGS. So as the previous speakers alluded to, we want to utilize the same praziquantel that remains during the MDS. We rechannel it and making it available also for treatment for those who are in need of it. And at the governance level, it's making sure that we have available policy documents. So together with the ministry, we have already started working on a number of documents, policy documents, training guidelines, protocols, and all that. And also the other part that we're working on is to make sure that we have high level engagement, because at this point, we don't have really a TIC WG that looks at FGS. It's mostly looking at the general schisto in the other entities, but want to have a task force that is focused on FGS to give it the attention it deserves. And at I'll focus on the last two bullets on service delivery, human resource at the point of care. It's also building capacity of the frontline workers. I mean, even health workers, most of them are not knowledgeable about FGS. They are not aware, they don't know it. So we want to start building their capacity such that they are able to provide the service at the point of care. We can move on. So this is our last slide. As Ruth indicated, we are just starting. We are young in the infancy stage in terms of our implementation of FGS initiative. So we are keen to learn from the other initiatives. We want to learn what is it that our colleagues have done already, and move that forward. Yes. So basically, that's what we are looking forward to. Thank you so much.
Thank you so much, Ruth and Chimamwe. Thank you so much. Now we have just very few minutes for Q&A, and I will already have some questions in the chat, which I will direct to the speakers. The first question will go to Margaret, which is asking whether there was an intentional inclusion of midwives in your training packages, and how does this contribute to universal health coverage? Margaret.
Thank you very much. Yes, indeed, we included midwives. In fact, they started the training with Geneva Learning Foundation, which was an online training. And then they were further trained as subject matter experts. And these experts were selected based on their interest and their completion of assignments. And many of the midwives were quick to complete this. I think the main reason they were saying was they've been examining women, but had no clue that they could have an opportunity to check for FGS. For them, it's a big deal. And even today, we are involving them in the mapping of FGS, where we are doing examination of the women and using the colposcope. So yes, we have been including women, and some of them, I tell you, are very strong champions of FGS in Ghana.
Thank you so much. And also there was a comment with regard to prevention, that it's really important to do prevention and to start early. And that was a message that it's a remark in the chat. We're following the presentation by Ashley from Côte d'Ivoire. And Leora, there is a question specifically for you as well with regard to how to really use this sexual reproductive health approach, and what would be your suggestions on the next steps about to combine what you've seen in Kenya and how that could be adapted by other countries to integrate FGS into their primary health care?
I think each country has its own journey. It depends on how this health system works. But I think what's really, really important is that we need people to advocate nationally and on the ground for FGS to be included, in particular frameworks and policies in the country, such as STI guidelines, national strategic plans for HIV. And in that way, you really engage with government and you get government to see the need to take on FGS, the links with SRH and HIV, and also really develop sound policy to support implementation further down in the healthcare system. So I do think at this point, it's really a lot about awareness raising and advocacy. We need champions, we need fierce champions.
Good, thank you. The very fierce champions. And my last question, which will be to Ruth, given the dynamic global landscape, and in your position as someone who's from a donor perspective and a physician, how can we effectively engage and encourage more international partners to be invested in projects focused on FGS?
Excellent question. It's a key question. I think not only we are asking ourselves, especially in these challenging times. You all follow the global news. So I think on the one hand, advocacy is key, and this webinar is contributing to this, but I think we really have to take forward also in best case scenarios, storytelling, movies. I think tomorrow we are all going to post something additionally to this webinar. So I think this is key. But on the other hand, we are working together with the BMZ, with our Ministry of Cooperation, on an analysis of the different financing possibilities and pathways to see if we can sort of grab at some finances of some of the multilateral organisms like the Global Fund, etc., to engage them more than they used to be engaged. So this is very roughly the strategy we are looking at.
Great. Thank you so much. The questions could go on, and I hope we'll have an opportunity to continue the discussion online on some platform. And I'll hand over to Yael to close us out and let us know where we can get more information. For this, I'm really grateful to have interacted with this panel of fierce advocates for FGS, and pleased to see you use your agency to support this. Over to you, Yael.
Thank you so much, Pamela, Alison, and to all the speakers. It was so inspiring. And I think we've all seen today not only that integration is possible, but it's also a really fantastic opportunity for innovation and for putting in place equitable and sustainable services for women and girls. So really, really inspiring. I think we have a new word of the day, and that word is fierce. I love it. And I would like to add to it one more word, which is impatient. We know enough already about FGS and where it is and what issues it causes to act. So let's make sure that we put in place services and we don't wait for more evidence and more research while we put interventions in place to support this really neglected issue. I hope you will all join this effort. If you would like to find out more about FIG, Leora's put information about us in the chat. Please join us. Please sign up to the newsletter. And thank you again so much for the Canadian Network for organising this today. Happy International Women's Day to everyone when it comes. Thank you. Thanks, everyone.
Thank you, everybody. Have a wonderful day tomorrow, and thanks to all our speakers.